Good morning, everyone. It is my pleasure to welcome you all to today's continuing professional development session conducted by the Society for Health Research and Innovation. It is my pleasure to welcome you all to today's webinar on chronic venous insufficiency from pathophysiology to evidence-based practice. It is indeed a privilege to introduce our esteemed speaker, Dr. Anura Prasanna Veerasuriya. Dr. Veerasuriya is a highly accomplished vascular and transplant surgeon currently serving at Colombo North Teaching Hospital. He is also a senior lecturer at the Faculty of Medicine, Prague. He obtained his MBBS and MD in surgery from the University of Colombo and further achieved MRCS from the Royal College of Surgeons of Edinburgh. Notably, he was awarded Best Student in the MD Exit Examination in 2013, reflecting his academic excellence. Dr. Veerasuriya has extensive international exposure, having worked as a vascular and endovascular fellow at Fiona Stanley Hospital in Western Australia. His expertise spans a full range of vascular procedures, including advanced endovascular interventions, and he has been actively involved in teaching, clinical audits, and multiple academic presentations and publications in vascular surgery. With his vast clinical experience and academic contributions, we are truly fortunate to have him guide us through today's topic. Without further delay, I invite Dr. Veerasuriya to deliver his lecture. Over to you, sir.
Thank you, Shanti. Thank you very much for your kind words of introduction. Very good morning to everyone today. Just trying to brief you through the management of chronic venous insufficiency. That's from pathophysiology to the evidence-based practice. That's as we know how we can treat with the rest of the world. So as you see, this is a very common occurrence. I see these kind of presentations when you practicing as outpatient basis or maybe in the hospital. You might come across these kind of patients coming to you very frequently. They have different presentations. So we see how they are as time goes on. Before I embark on the proper talk, I thought I might share with you some of the common case scenarios. So I hope at the end of the talk, you should be able to answer on how we can manage these patients effectively. So that's my aim. So this is basically one of the 55-year-old man who had been having this chronic ulcer in the left leg, just about the median malleolus, going for 3 years, and it's painful. So how we manage this patient is a problem. Second, this man is 50-year-old middle-aged man, again coming with the painful legs and also some varicose veins in the legs. And this is a fairly young lady and having some varicose vein visible and around the ankle area. So these are some of the cosmetic issues of most of the ladies nowadays. So these are my learning objectives to you. So at the end of the talk, you should be able to define what chronic venous disease, the CVD, and chronic venous insufficiency. So, and the current classification framework, what they are, and explain the pathophysiology of the linking reflux, obstruction, muscle pump failures. So the other one is about applying a structured diagnostic practice using different classification system and also investigation results. And then the treatment wise, compare conservative, pharmacological, so whatever the treatment modality we have. And lastly, translate the major guideline recommendation into clinical practice. So in terms of definition, so we can talk about the chronic venous insufficiency. There's kind of a broader term, but we need to understand what chronic venous hypertension is, like arterial hypertension. So we have venous hypertension also. So it is actually a sustained elevation of venous pressure in lower limbs during ambulations. Even during ambulations, your pressure is in the lower limbs high. So that's the basic problem here. I will explain to you how it happens and later on. And the final common pathway is the development of chronic venous disorder, leading to skin changes, edema, ulcerations, and so on. So the other term is chronic venous disorder. So disorder is actually equal to full spectrum of long-standing disease associated with chronic venous hypertension. So Then, of course, chronic venous insufficiency, another term, that is insufficiency. But generally, chronic venous disorder is an umbrella term. So it actually characterizes all the disorders associated with chronic venous disease, starting from very minor disease to advanced disease. Whereas chronic venous insufficiency usually referred to advanced disease. So in talk about etiology and risk factors, so it is very common, So if you come across the population wise, the one of the it's very frequently present in given populations. In given population, about 30% of the population people have venous disease associated with this problem. So you can see the disease burden how they are. And then the varicose veins affect the quality of life and more important, the productivity at work, because this is a nagging issue and it's just a chronic issue. And even though it's more subtle, but it may be very hazardous and troublesome to one of the patients with chronic disease like venous ulcer. And then, of course, the absence of work and a lot of healthcare utilization issues come into play. Then the venous ulcer is the most expensive way of managing to patients, because sometimes patients do come to us with very long-standing ulcers, maybe 5 to 10 years, and then no treatment has been offered, or perhaps nothing has worked for the patients. So this is by that time patients come, they might have spent millions of money giving different wound care and all sorts of things. So who are the patients who are at risk of developing these things? So one of these is the female gender. So these females have high risk of developing venous disease compared to male. And also when you go with your age, so advanced disease, another entity, obesity. If you put on weight, certainly you're going to have varicose veins. And also having prolonged standing, and particularly if you're having family history of varicose disease, so then you're prone to have, especially if your mother or father is having varicose veins, you be having a 60% chance of developing varicose veins. So parity is also another important thing. So as pregnancy, number of parity leads to increase in propensity to develop venous disease as time goes on. And you also need to ask whether the patient has got previous to deep vein thrombosis, and that of course increases risk of venous disease. I will explain to you later how it happens. And the mobility. So, and the reduced ankle mobility is the other important character thing about this disease. This is the global prevalence of chronic venous disease by the SIA class, that is the standardized classification system. I will explain to you later what this is all about. But as far as the SIA is concerned, so the C0 is presenting the very subtle disease, minor disease, whereas C6 is advanced disease. So majority falls into C1 disease, that's an early disease, but later on the C6 is actually representing those ulcers, so it's very advanced, but it's subtle, minor fractions. But majority of them have varicose veins and other issues in the given population. So why should we care of this vein? Thinking is that even though it looks benign, but usually can progress to a very severe disease like edema and dermatitis, sclerosis, skin pigmentation, and all sort of things. And some of the things are like alarming to patients and bleeding. It's just bleeding, it spurts. The patient find very disappointing and also difficult to control. Sometimes the patients complain that I had just about 1 pint before I come to hospital. So this is one of the presentation and alarming to patients. And some of the things when you have varicose veins lead to superficial thromboembolitis, so and venous ulcerations, most severe disease. And the other thing is chronic venous disease is a systemic disease. Actually, it affects multiple problems. One thing, the problem with the hemodynamics. Secondly, there's inflammation going on. There's a problem with the microcirculation. Then the wound biology and the other issue when it comes to a wound. And the imaging and intervention is important aspects to look at. So current practice has shifted from the compression first to everyone. So because this was the initial initiative in NHS in UK, So they gave compression only to each and every patient who has venous disease. But nowadays we know early definite treatment is much beneficial than just symptomatic control with compression stockings. So examination with a good history is very important. Nowadays, we need to know whether to operate or not. That's the first question we need to know. And if so, which patient we should operate? That's the second question. And which vein? The third question. And which modality is the other one? And what evidence is there to support us? So before we embark on the abnormality, that's pathology behind this, we'll get on to the normal anatomy, just to brush up your knowledge. So this, the lower limb venous drainage usually happening in deep two system, deep and superficial system. The deep system carries bulk of the venous return, and so 90% of the deep veins, blood in the veins carry in the deep veins, whereas superficial system contributes only about 10% of the venous drainage in all. So superficial system again has two components, long saphenous and short saphenous. And deep system has femoral, popliteal, tibial veins, that is the bulk. And the perforators are functioning from superficial to deep, connecting both superficial and deep system together with the presence of competent valves, which are directed from superficial to deep, not the other way. And their own venous valves are important in terms of venous return. And here you are, so the long saphenous vein is actually on the medial aspect, coming on the medial side, and then along anteromedial thigh, joining the saphenofemoral junction. That's the largest perforator in the lower limb. So where you have saphenofemoral junction. And then we have the short saphenous vein, which is draining on the back of the calf area and joining the saphenopopliteal junction. There's another contributory called intersaphenous vein, which sometimes communicates with short saphenous vein with a long saphenous vein. That's called Venous Giacomini. This was actually described by Carlo Giacomini in 1873, and which we recognize that this is as abnormal vein, which is usually communicating with the short saphenous vein with the long saphenous vein. So this is an intercommunicating vein. So it usually can give rise to abnormalities and reflux in vein. So the other one is a long saphenous vein anatomy. You see now, long saphenous vein in the thigh is highly variable. Sometimes we have duplicated system. Usually, long saphenous vein lie in the saphenous fascia. You see that this line demarcates the fascia, and over that there's a saphenous fascia. Within this fascia, you get the vein. So look, it's something in normal radiology we call it a saphenous eye. So usually it's lying within this fascia. Sometimes there's an epiphyseal vein also, because it's a duplicated system. Sometimes we have epiphyseal vein dilated, but this is rudimentary, which is inside the saphenous fascia is rudimentary. So you need to delineate which fragment is affected by proper scanning. The saphenopopliteal junction is very highly significant when it comes to an operation or a surgical procedure. The tibial nerve is in the cross proximity, so you need to know the anatomy well before you embark on the surgical procedures when it comes to popliteal disconnection and all. And the physiology. So I talked about the anatomy now. Now it's physiology. How we drain the lower limb venous blood back towards the heart. So there are four mechanisms. One thing is the intact carpus pump. Second is the competent valves, which is preventing reflux. And the third one is ambulatory so venous pressure, which should fall during walking. So there are two other mechanisms. Something is the presence of veins joining the artery. So when the arterial pulsation transmitted to veins, which can also propagate some of the pulsations into the vein and can vary, but very subtle things, but important. The other one, a negative effect for the chest wall during inspiration. So it sucks blood towards the heart. So that is the other mechanism, drawing blood back towards the heart. So most important thing is the corpuscle pump, which is acting as a secondary heart for the venous return. So this is how it is. Now deep veins are surrounded by deep muscles, like in the leg below knee, we have soleus muscle, which is actually covering the deep vein. When soleus muscle contracts during walking, the ankle movements, so it actually pushes the deep vein, and it actually push the blood forward. In the presence of competent valves here, it prevents reflux. Excuse me. and then it prevents return of blood back. So that is the other thing. So then about the normal physiological variation with the upright posture, we develop all these venous disease when you're upright. If you're on your force, like in dogs and cats, so that it's not going to develop. So this is all because we are in upright posture. That's where the gravity plays a huge role. So in your upright posture, you see that this diagram shows very well about the pressure differences that happen during standing posture. Your normal at heart level artery pressure is 100, whereas venous pressure is 0. But when you go down, the artery pressure is going to up to 190. But there are pre-capillary sphincters which going to protect the capillaries, so preventing any problem. Whereas venous pressure is going to be about 90 to 100 millimeter mercury. So that's where the problem lies. So then about the pathophysiology, all these problems do happen because of the valvular incompetence. That's one of the mechanisms how it have uh, the, um, the development of these disease. The venous obstruction is the second mechanism. Calf muscle failure, other etiology, and microcircular dysfunction. So all these four things are important, and we need to understand. It's just not only the valvular incompetence and superficial vein which leads to the development of varicose veins. There are three other. So venous insufficiency in terms of valvular incompetence is one of the most important driving pathology. That's where most of the surgeons embark on doing venous interventions, thinking this is a superficial venous disease because of valvular incompetence. So when you in standing have risk factors like what I told you previously, you develop varicose veins because of degeneration, and there's a elongation, dilatation, and abnormally tortuous vein. So this leads to the development of incompetent valves. So when the vein wall dilates, it leads to incompetent valves. Invariably, these going to reflux. So because the valves doesn't get dilated, even the vein got dilated. So that leads to development of reflux. So this is venous insufficiency by incompetent valves. So it can be primary due to degenerative disease, or maybe secondary, like post-thrombotic syndrome. Like I will explain to you that later, how it happens, or maybe a combination of both. So the venous obstruction actually can happen due to deep vein thrombosis, because I said to you, DVT, I said your deep veins are the ones which carry bulk of the venous return. So if the deep veins are blocked, so there's no other way of draining blood back towards the heart. So the only draining system is the superficial venous system. Then, of course, the superficial veins get dilated. So that obviously is a natural physiological mechanism to drain blood back to the heart. So if by any chance you're going to deal with the superficial vein in that kind of patients, it's going to worsen the patient's problem. So you need to understand there's a DVT or not in these patients. So leading to the once you have DVT, the venous return get obstructed in the long term, because the DVT in natural sequel, even though you start anticoagulation, the venous recanalization is incomplete always. So that leads to chronic venous hypertension in the long run, in the deep veins. So the superficial veins get engorged with blood because it's the only drainage system. So they develop dilatation and varicose veins. So that is leading to chronic venous hypertension, and this is termed as post-thrombotic syndrome. So other thing is whether you can have iliac vein compression. Classic example of iliac vein compression is the gravid uterus during pregnancy. You can get this, and then once a baby is delivered, this iliac vein is not compressed, so it is a transient problem. And then we have sometimes outflow resistance with the venous pressure. So ambulatory venous hypertension happens because of failure of returning returning the venous pressure to a pre-existing value is called ambulatory venous hypertension. So this graph shows you how it exactly happens. So usually when you stand still, your venous pressure, I said you were 80 to 90, somewhere around 80, 90. So when you are taking the first few steps, your venous pressure drops down to about 20 millimeter mercury because of the intact calf muscle pump. that actually pushes and works as a secondary heart to drive back the blood back towards the heart. So that happens in 20 seconds. So with the first few steps, this actual pressure drops to drastically low value. But those who have incompetent valves, so this pressure doesn't go down so faster, and it actually drops down to about 60. But basically, it returns to the baseline value, which is about 90, very soon. Whereas normal individual, you and I, that test take about 70 seconds. So that is the danger. So you see now the early return of venous pressure leading to persistent venous hypertension. This is the problem. You see now those who have the deep venous problem, insufficiency, that is much more greater in normal people. So this is the graph shows you pressure returns very slowly, whereas the deep venous issues, the pressure returns very faster and perhaps to pre-existing value very sooner. So this again shows the physiological mechanism when you're in upright posture, walking and sleeping, and the upside down posture. You say when standing, this pressure is high. So you take first few steps, the severe incompetence pressure is very high. Normal, this pressure drops to very low level. And then obviously stopping that leads to again a return of venous pressure. In a supine, no issues, no worries. So you don't have to worry about the veins if you are sleeping and declivity. So if you're on the other side, so there's no problem. From skin changes, venous ulcer development, this is a stasis dermatitis because the chronic venous hypertension, the venous pooling, that leads to dermatitis. Most of the skin specialists get touched with these conditions, and they might treat with a lot of emollients and steroids to get rid of these issues, but usually it's of no use because you're not going to treat underlying disease, then it's not going to resolve. And then there was the lipodermal sclerosis, the inflammatory is kind of inflammatory manifestation, and I'll explain to you how it happens. And so there are microvascular issues. One thing is there's a leukocyte trapping. So inside the microcirculation, the leukocytes are going to trap. That leads to a lot of issues. And then the fibrin deposition and other issues. The fibrinogen is a molecule that has in the cytoplasm and get filtered into its capillaries and into the interstitium and that leads to fibrin deposition. So fibrin get deposited around the capillaries. That actually limits the all the nutrients getting into the tissue level. So there is a tissue level hypoxia and depletion of micronutrients because of fibrin deposition around the vessel. So that is an issue. And there's MMP regulation that's because the inflammation led by the leukocyte trapping, lead to matrix metropolisis upregulation and leading to edema and irritation, lead to itching, and later on develop ulcerations. So microcirculatory dysfunction, so there's a leukocyte trapping, as I told you, and the endothelial activation and lead to inflammatory cascade. And capillary is going to leak out, fibrin cuff, and tissue hypoxia and ulceration. So these are issues. You see the same thing here. The venous hypertension leading to all these dermal changes. As you see in these patients, there are skin pigmentation. There's a chronic long-standing ulcer. So you see that we can get this typical ulcer in the gate area. And it is very itchy. So patients do get the pleasure of itching in this region, but later on they suffer quite a lot because of pain and development of ulcers. So this is in a nutshell how the pathophysiology lies. Triggering factors are valve failures, maybe obstruction or calf muscle failure, then leading to ultimately to ambulatory venous hypertension. And then we get a microcircular change, we get dilatation, reflux, the venous wall remodeling, then the ultimately leading to the endothelial activation, leukocyte trapping, MMP activation, capillary leakage, leading to clinical sequence of edema, skin change, and ulceration. So some of the clinical manifestations you should be aware of. So what is this condition called atrophy planche? You see the white color appearance of the ankle region because of the venous pressure. the skin become atrophied. So this can sometimes get mimicked by this application of steroids on long-term use if you're doing because most of the general practitioners prescribe steroids for itching of the lower limb, so that also leads to hypopigmentation. This is slightly different. It's not steroid-induced hypopigmentation. This is little because of chronic venous hypertension-induced skin change. Then we have something called telangiectasias and reticular veins, which are commonly known as spider veins. So telangiectasias are the smallest or tiniest veins in the venous spectrum, so which are about 1 millimeter size vein. The reticular veins actually slightly bigger, about 1 to 3 millimeter size vein. So they cumulatively we call it as spider veins, and this causes a lot of cosmetic problems to young ladies, particularly. So the other one is called varicose veins. Varicose veins are actually veins which are larger than 3 millimeter in diameter. So you see the spectrum of disease starting with the telangiectasias, the reticular veins, and the varicose veins. This is corona plepectitica. So you see some of the spider veins appearing in and around the ankle area. There are blackheads. So those are which are called corona plepectitica. So this is lipodermal sclerosis. You see, the skin is actually thickened, lipid undergoing necrosis and sclerosis. So that is why it's called lipodermatosclerosis. Skin is very thick and scarred, so leading to skin changes like this. So this is typical of venous disease. And sometimes you get hyperpigmentation, that's hemosiderin. This because the chronic venous hypertension that gets manifested into the transmitted into the vein capillary bed, leading to extravasation of RBC. So this RBC get extravasated once it's lying outside the vessel, lead to destruction of the RBC that has heme inside, and that heme get deposited on the skin. It leads to bronchial appearance in these areas. So that is the hemosiderin deposition. So this is a very large the last disease spectrum of disease, so the development of active venous ulcer. You see all the changes here. So the very superficial ulcers in and around the ankle area. On the medial side, it's the gate area. We see shallow ulcers and pink in color. We generally can assume that these pink color appearance is representing granulation tissue. But granulation tissue is a hallmark of healing ulcers. But usually these venous ulcers have, even though granulation tissues, which are usually unhealthy, which is covered with a biofilm or that, and which is not healing. How much you try to heal this, can heal with conventional dressings. And there are dermal changes. You see the skin pigmentation and edema. So those are problems. So these are early venous ulcers. And deep vein thrombosis, in a nutshell, this is what happened: development of the clots inside the valves initially, then because of stasis of blood, or maybe hypocoagulable blood or the endothelial injury. So these are the Charcot's triad in development of venous thrombosis. So any of these things can go into development DVT. Once the DVT develops, so that they lead to obstruction of the veins and leading to what is called post-thrombotic syndrome later on. So this is about classification systems. We have CEAP classification, CEAP, CEAP. So this is the international classification system of the venous disease. The C standing for clinical, E is for etiology, A anatomy, P pathophysiology. So different classes are there, 4 classes. Depending on that, there's a standard categorization system. We usually go by clinical parameters to classify disease. And C0 to C2 varicose veins, C3 is the development of edema, C4 is skin changes, C5, C6 healed and active ulcer, C5 is healed ulcer, C6 is active ulcer development. So, so when you actually use these classifications, anyone in the rest of the world can understand what we are talking about. So that is a standardized classification system with the rest of the world. So see this is illustrated way how we can see that. C0 is no veins visible. So this is very early disease. So C0, C1 is telangiectasia reticular veins, C2 is varicose veins, C3 is edema, C4 the pigmentation, and all the skin changes happening there. C5 is the healed ulcer state, C6 is advanced ulcer state. So there is another, now there's a CIAP has classified, revised its classification system in 2020. So some of things changes added into this C4, actually C4 is actually skin changes which are attributing. C4C is actually linked to corona pevectitica. C4R is linked to recurrent varicose veins, and recurrent ulcer is C6R. So this is how it has nomenclature differed. These are subtle changes, but it's worth knowing it. Then etiology, we call that disease to intravenous cause or extravenous cause. Then the anatomy, what the common anatomical aberration, we are usually going by numerical values before. Now we usually go by common anatomical aberrations for the ease of nomenclature. Pathophysiology, we usually have reflux or obstruction or combination of both, which remain the same. So then we come to VCSS classification system, that is revised venous clinical severity score. This actually stratifies the venous disease into mild, moderate, severe. Even though the CRP usually just classifying just on the clinical appearance only, we usually go by symptomatology of the patients and stratify patients' parameters according to the different categorization. This is important for research and purposes, and also quantifying the symptoms and signs of patient's problem. We can track the response of the patients. Once the treatment is initiated to the first patient, we can go by VSS score to note whether the patient has got benefited out of the treatment or not. So this is a major advantage of using VCSS scoring system in terms of the classification. Then the diagnostic workup, you see, history is the most important thing when it comes to diagnosis of this disease. You see there's symptom phenotype. There's patients who come to you most commonly with pain. Which is aching or heaviness, very vaguely. Sometimes patients do come to you. So we need to identify which type of pain this is, because these you have to understand these, most of these patients are quite old age, or perhaps middle age. They have associated other issues like inflammatory arthritis or degenerative arthritis, having leg issues. So in these situations, the pain, of course, very non-specific. You need to understand this pain is related to varicose vein or not very clearly. Otherwise, you're going to treat the patient in vain. So ask clearly, this pain get worsened towards the evening, and also with the standing up, and also should get relieved after keeping the leg up. Or perhaps when the gravity is eliminated, does this pain get relieved? That's the first question you should be asking in these patients. So if the patient's pain actually worse in the night and having other issues, so it is not varicose vein issue. So varicose vein issue is always something to do with gravity. So if the gravity is eliminated, the pain should disappear. So you need to ask this very clearly. I'm stressing this over and over again because otherwise patients do come to you back again saying that your pain is still there, how much I got rid of my varicose veins. So you have treated the patient in vain. Instead, patient might have osteoarthritis and other issues. So that is not treatment failure. That's because of incorrect treatment of picking up the incorrect patients for treatment. The swelling, again, you need to understand swelling is also important. Sometimes unilateral swelling is significant of varicose vein. Bilateral swelling, you need to always exclude any systemic pathology like heart disease or heart failure, or maybe liver issues, kidney issues. You need to always exclude these things before you come to diagnosis. Swelling as the only cause for for the varicose veins. So then itching, night cramps. Sometimes patients come with night cramps. So that is characteristic of varicose vein. Restless leg. So sometimes diabetic patients also complain restless leg in the night because of chronic neuropathy. They have neuropathic pain, which is worse in night. So you need to ask whether this is something to do with nerves or whether it is something to do with restless leg associated with night cramps. So venous claudication because of DVT, so and bleeding issues. The progression markers like edema, eczema, pigmentation, you need to ask these things. So all these changes we can examine and see whether this patient has a healed or active ulcer. Always check whether there is history of DVT or superficial thrombophlebitis, pregnancy. These are contraindications for treatment, any intervention, or prior venous intervention. See whether it's a primary varicose veins or recurrent varicose veins. If it is recurrent disease, we need to embark on different plan of management than just conventional treatment. So you need to find out the functional exam also. So that is you need to check whether BMI, if the patient is overweight or obese, you need to bring down the patient's weight. Otherwise, how much you can treat the patient, you need to warn the patient so you can have recurrence of disease in the near future because the risk factors are still same. Try and see whether you can minimize risk factors, particularly BMI, and see whether the gait and ankle mobility is okay because the ankle is not mobile. You have problems always with the deep veins because the ankle mobility is highly important for your walking and also the calf muscle pump. If the muscle pump is ineffective, how much you're trying to deal with the superficial veins, not going to be effective. And you always check the pulses on the limb. So if you are going to embark on venous disease, so you need to have good palpable pedal pulses. If the pulses are not felt, so that means there's always a problem. So it may be accompanying arterial disease along with the venous disease. Particularly this happening in diabetic patients. So we'll be very highly vigilant. This patient, you can feel the pulse of this patient or not. So these are the questions I have in mind. So if this is a primary test, yes, you need to do a duplex scan is a diagnosis choice. The patient position. So when you come to investigation, diagnosis, the duplex scan is a course of investigation choice. So that is the important thing. There's you don't need any other hi-fi machines to diagnose disease or quantify the disease. Then how do you position this patient? This is highly important when you are particularly a sonographer or radiology physician. You need to keep the patient in a dependent position. Otherwise, you're not going to elicit the reflux disease because this is a problem with the gravity. So best position is seated position. Or perhaps the patient not able to sit, so you need to give the patient a reverse trend position. So that is a head up position. And then the superficial, there's a threshold mark. So for superficial veins, for you to diagnose reflux, the reflux time is more than 0.5 seconds. So that's more than 500 milliseconds. They are no saphenous vein, no short saphenous vein. And the deep vein, the threshold is 1 second. So that is 1000 milliseconds. The perforators you consider as abnormal if the refluxing time is more than 500 milliseconds, again, like in superficial vein. And also perforator diameter also matters. Perforator diameter more than 3.5 millimeters is significant. If it is less than that, you can't call it as a perforator incompetence. So when you actually demark, you're telling that there's a perforator incompetence, there are two things we are looking at. One thing is the reflux time, the other thing is the diameter of the perforator. So these two are important when you want to diagnose perforator incompetence. I hope that message is very clear. And the important principle is trace the reflux to source, document the anatomy and the diameter, and also reflux waveform with calipers. So this is what you see. You see now that this is the deep vein, the superficial vein, you see. So you're actually doing what's called augmentation. So you're actually squeezing the calf muscles, and then you see the reflux time. This is the reverse flow. This is augmentation, and this is reflux. With the reflux time is highly significant. If it's more than 0.5 seconds, this is 1, 2, 3, 4, 5. So this is highly significant. So this is a perforator issue. So you see the perforator is a perpendicular communication with superficial and deep system. So there are perforator incompetence. So either the perforator diameter is long and the reflux time is prolonged. So do we need to do anything else other than duplex? Yes, there are some other situations where we need to embark on other modalities. We need cross-section imaging like MR venous venogram, CET venograms, venography, intravascular sounds, plethysmography. These are indicated selected patients only. If you are actually planning or suspecting iliocaval obstruction or high up iliofemoral obstruction, we need to do this kind of test because ultrasonography is not very sensitive in the abdomen. because the iliac veins are retroperitoneal, because your bowels are in the front, so you may not be able to differentiate the retroperitoneal tissues structures well in the ultrasonography in the abdomen. Then the recurrent disease if you are not sure about the anatomy, so we need delineate anatomy, the recurrent disease. Sometimes we have pelvic origin varices, vulvar varices. So then we have to check whether there are vulvar the internal iliac reflux. So there we have to embark on doing these kind of things. Then about the management. So you need, more important thing is you need to treat the symptoms, not the patients, just not the patient's wishes, but treat the symptoms. And so that's where diagnosis is highly important, whether this is symptomatic patients or not. If the patient have no symptoms related to varicose veins or venous disease, just leave alone, because that's not going to make a difference. So treat symptoms of the patient. That's highly important to understand. And then second thing is prevent the progression. You need to prevent the progression of disease and correct the hemorrhagic lesion if appropriate. So that's the thing. So these are the principles of management. One thing is reduce venous hypertension. So because we know persistent ambulatory venous hypertension is the driving pathology here, so you have to reduce the venous hypertension if at all. So improve the venous return. So at the same time, then if there are ulcers, you need to heal ulcers. Even though you heal ulcers, the ulcers do recur. So you have to prevent recurrence. So you need to do something to prevent recurrence. Then about improving cosmesis is the last thing, but patients are quite worried about it. So do you do conservative treatment nowadays? Yes, in selected patients. But before you embark on any interventions, you need to educate this patient, explain the natural history, because it's like asthma. Asthma is a chronic disease, but it's just a symptomatic control then and there. Like this one, in lower limb varicose veins are treating then and there if the patients are symptomatic. You have to warn the patient that this is going to recur in the future. Maybe how successful you're going to treat for the varicose veins and the venous disease is going to come back in another 10 to 15 years. So you need to warn that it's not just the treatment failure, it's just the natural sequel of the disease. So you need to tell this very clear to the patients. Otherwise, patients will get so disappointed after 10 years saying that I have that again, varicose vein again. So, but educate the patient and also minimize the risk factors if possible, like weight control, walking, calf activation, that ankle mobility. So avoid prolonged mobilization. We have to always advise these measures to prevent recurrence. And also skin care and emollients are important because they lead to dry skin, dermatitis, edema. So they need to manage these factors also in the treatment modality. So the compression actually is a cornerstone of treatment when it comes to edema control and also ulcer management. So that is a cornerstone. But again, for reflux disease, so we can treat some other definitive interventions. And always exclude any arterial disease accompanying this patient, like checking pulses. And also we can check ankle brachial pressure index, ABPI assessment, highly important. If the ABPI is less than 0.9, it's always abnormal. So you need to defer any other treatment, thinking this is maybe a mixed arterial disease. So compression treatment may be indicated for early disease, truncal with symptomatic truncal disease, but it's just only buying time only. But usually can give for compression, give this kind of compression for edema control. But there's a trial of stocking we can give if we are not very sure the pain of the lower limb related to the varicose vein or not. We can actually diagnose venous disease by giving a trial of stocking. So if the patient's pain after a while, after wearing the stocking going away, so you can diagnose this is really related to varicose veins. If the pain is persistent even after wearing stockings, so this is not due to varicose vein. You have to confidently you can say that this is not a venous disease. It is not related to venous disease. It may be a degenerative disease like osteoarthritis or other disease, which may be related to the joints. So, and also After thermal ablation, we give trial of stocking also because to have edema control. And there's venous ulcer, we have to do stocking, we have to do compression, commands. So there are venoactive drugs also. These are, mind you, these are highly commercialized nowadays. People are, a lot of pharmaceuticals companies are propagating the information to practitioners that this is highly effective. But you need to understand none of these are highly proven. However, MPFF has got some value here. That is micronized purified flavonoid fraction. That's Daflon. Daflon is a diaspin fraction of Daflon, which is expensive. This going at 600 milligram twice a day. At least if you want to have therapeutic effect, you have to give for 3 to 6 months. So you can imagine how much is money cost. But there again, it's usually evident in the early disease. C1 to C2 disease, not in advanced disease. And C6 disease may get benefited with the ulcer improvement or ulcer healing, but usually that's not the case. There are special situations I do certain circumstances where you do consider, you think twice before embarking on interventions. So pregnancy, such conditions, always reassure the patients because this is problem gravid uterus, compression is the problem. So you manage the patients conservatively because otherwise it's highly risky to manage because this is a reversible condition. So once the baby is delivered, there is no problem. And compression maybe is the only way forward in these kind of situations. Sometimes it has exceptionally, you can consider there's bleeding issues with varicose veins in pregnancy. You can consider an intervention, but not one otherwise. So you have to reassure. Sometimes we have recurrence and complications. We have recurrent veins. We need to do a repeat duplex mapping and control the source, and then we had drive the empirical treatment based on the abnormality of the vein. So you need to talk about the DVT and other problems associated with intervention. Then come to superficial venous intervention. So we have three modalities of intervention of superficial system. And that's the endothermal ablation. Then we can do foam sclerotherapy, and then other one is a surgical ligation stripping. The endothermal ablation is three forms. We can do we can use laser as a modality. We can do radio frequency ablation, RFA as a modality, or we can do microwave ablation as a therapeutic modality, out of which the laser is superior. I'll show you how it is. The foam sclerotherapy again can be of three forms. We can use high osmolar compounds like 20% dextrose and high osmolar compounds, or maybe you can use alcohol-based preparations like glycerol. We can use maybe we can use detergents. Like if you're having a strong detergent, it actually destroys the endothelium of the vessel. That is the STD, sodium tetrahydrosulfate. That is when you mix it there, it actually forms microforms. It's like soap. So that of course we can use for treatment. Then the last is the surgical ligation stripping. So out of this endovenous option, RFA, endovenous chemical, they all are endovenous options. They can use mechanical ablation, that's MOCA. And we can add tissue closure like cyanoacrylate glue we can use to obliterate the vein. So we can use sclerotherapy. So these are the minimal invasive techniques nowadays people have evolved. The rest of the world is evolved with these type of techniques. I'll show you which one is superior based on the evidence. And so thermal versus non-thermal, thermal is superior. So when you use thermal ablation, we need to do something called tumescent anesthesia. You need to pay attention to prevention of skin and nerve damage. That's why tumescent is important. And that is way forward. And non-thermal ablation, avoid tumescent anesthesia. There's no need of anesthesia, like MOCA, mechanical chemical ablation. And so, but EVLA, that's thermal ablation, is superior. So this is how we do thermal ablation. There's a machine which delivers the laser, So under ultrasound guidance, we can cannulate, and then this is the catheter, which inside the catheter has laser fiber, and actually going to destroy the vein. This is the conventional surgery. There is you have subinfloor ligation and stripping. So there are about 6 branches when it comes to subinfloor ligation. So you have to ligate individual branches. And there's an important thing is during dissection, there's a constant artery going underneath the subinfloor junction. That's a superficial external epidural artery. So that can get damaged, but it's not very problematic, but it can sometimes lead to troublesome bleeding. So you need to be very careful not to damage that. And then we do something called stripping. You have to go for stripping of the long saphenous vein. Once you disconnect, you strip up to the knee, not beyond, because beyond what you do is a multiple step eversions. Early days we used to go multiple step dissections and ligation and all sort of things. What we do now is the multiple step eversions. That's a number 11 blade is used to make a small steps and at multiple sites. Through multiple small step, we can actually pinch that vein, affected vein, to that small incision with a fine mosquito, and then we can pull it, and then we can strip the whole vein involved with multiple eversions. So that is the way forward, and it doesn't need any. It has minimal scarring because it's a stab only, and it doesn't need suturing. So this is the other problem. If you inadvertently damage or excise the competent long saphenous vein along with the incompetent below-knee vein, so that leads to worsening of the the existing varicose veins, because the competent vein actually has become the superior pathway of draining the varicose vein, venous blood. So removing that can actually worsen the patient's problem. That is why it's highly important to delineate what the abnormal vein lies, and then treat the abnormal vein only, not the whole thing, convention. So this is the another minimal invasive technique, ultrasound guided technique. Is a form sclerotherapy. We can treat that even for truncal veins. So these are for telangiectasia and reticular veins, which you can do with the liquid sclerotherapy. So these are the interventions for severe venous incontinence. If the patient is symptomatic long saphenous vein reflux, the endovenous ablation is the way forward. If it is short saphenous reflux, endovenous ablation again is the preferred option. If it is accessory saphenous reflux, we can use thermal or non-thermal ablation, tributaries, microphlebectomy, foam sclerotherapy. If intravenous unavailable, you can do other modalities. So evidence is, this is evidence, and so superficial ablation improves symptoms, reduce ulcer recurrence, many invasive is preferred. These are landmark trials we have. ESCA trial, which usually did the surgery versus compression alone, which has shown to reduce ulcer recurrence with surgery. That's all. So you see now, people have randomized. This is done very early, and then noted that this is the initial trial, 2004. You see the randomized 2 arms, compression only versus compression plus surgery. So with those who are having venous ulcers. So compression, or whether you do intervention, there's not going to make a difference in venous ulcer healing. Ulcer healing rate was the same. But in the long run, after 1 to 2 years, what happens is that ulcer recurrence rate was slower in those who had surgery. So this is the cornerstone for understanding of our intervention nowadays. So if we do actually treat varicose veins and other venous disease, superficial veins, we are going to prevent the recurrence, but we are not going to make a difference in a venous ulcer healing. So that's when you do surgery, open surgery in 2024. 2004. Then they come to Euro trial. Euro trial actually done in 2018. So this is actually used endovenous ablation versus in patients with venous ulcers versus surgery. So then the ulcer healing rate was faster. We noted the ulcer healing rate has been faster in those who are in endovenous ablation. So also reduce recurrence risk. So this is the evidence. Initially, in few days after surgery, whether you do surgery versus the ablation, compression, so the same kind of ulcer, not much of a difference is ulcer healing rate. But at the end, after 1 year, ulcer healing rate was faster. So nowadays, what the evidence is that do not wait until the venous ulcer to heal before embarking in venous intervention. So we can do laser to treat varicose veins, and the ulcer healing rate is faster. Compression remains still the cornerstone treatment in the venous ulcer healing, and long-term follow-up is important. And this is 2019 evidence, that is class trial. So people have actually got so many modalities. One thing is 3 arms, laser ablation one arm, foam sclerotherapy other arm, other one is surgery. So this is other trial, actually done in 2008 to 2011 centers in the UK, and including 719 participants. So laser ablation has been superior again out of all these modalities, and it is the most cost-effective and also considered first-line treatment modality in terms of treatment. And then we have another evidence, 2025 LAMA, which is EVLA versus MOCA. MOCA is minimal invasive mechanical chemical ablation. We have used the wire into the vein under ultrasound guidance, and mechanically you disturb the endothelium vessel. And also you inject foam sclerotherapy. So this is mechanical chemical ablation, but out of which the laser EVLA carries the highest success rate in terms of prevention of recurrence and treatment success. The Cochrane evidence is actually again a multi-layered. The with venous ulcer, multi-layer strapping is superior. So how much you strap, you have to maintain the pressure of the ulcer-bearing area about 40 millimeter mercury. That is the standard pressure you need to exert. So high compression improves healing. So both SPS, that is Society for Vascular Surgery, and also AVF, that is American Venous Forum recommendation, is that AVL and RFA are considered the first line and most effective modality treatment. And so both modalities are superior to open surgery, and EVL and RFA are superior to foam sclerotherapy, and liquid and foam sclerotherapy is only a treatment for telangiectasia and reticular veins and also some of the varicose veins. So deep venous ulcers, only a few slides here. So if their iliac veins are occluded due to previous DVT or maybe something called May-Turner syndrome, where we have compression of the right common iliac vein, left common iliac vein by right common iliac artery. So we might actually go for stenting of the iliac vein. So then improve the outflow of the vein of the left lower limb. Sometimes you go venous, deep venous reconstruction when you are destroyed with deep venous valves. So you can go for valve repair. So these are highly academic and research purpose only, and not much of benefit in the long term. And so deep venous obstruction, you might you might go for reconstruction if the iliofemoral obstruction. So ulcer management, cornerstone treatment is compression. Then the wound care principles applied here. Then obviously if the ulcer is infected, we need to treat with antibiotics. Usually it's not indicated. We can do general therapies. And sometimes venous ulcers, we need to identify venous etiology, use effective compression. If there are superficial reflux, treat the superficial reflux with the endothermal ablation, and prevention of recurrences by endothermal ablation. And compression, there are different compression elements. Ideally, it's a strap-in. Strap-in doesn't matter how much, however much you have strap-in, but it is an effective compression in and around the ankle area, which is 40 millimeter mercury that is required for venous ulcer healing. So you can get the same thing with class 3 stocking, but people do not wear the stockings. They are very troublesome to wear. So there are different classes of stockings. Class 1 and 2 are usually indicated for varicose veins. Class 2 is ideally indicated for DVT management. 3 and 4 are usually indicated for lymphedema and all. So advanced wound care principles apply, negative pressure therapy, you can do any of these, skin grafting, biological dressings, and limited. And recurrence, prevention of recurrence is a cornerstone of treatment. So long-term compression is highly important. Educate the patient, control the weight, exercise, early treatment reflux. So post-traumatic syndrome, I have explained to you this before, development of complications leading to high venous pressure after having DVT. And this is snapshot evidence of how it says if there's a deep venous stenting is only indicated in very selected cases only. And then the early ablation for venous ulcers plus compression is indicated. That's what the EBRA says, EBRA trial. Then the intravenous, which option? There's a laser is the best. Intervention, the long-term compression is highly important. There's a strong evidence. And duplex ultrasonography is the best modality of investigative choice in terms of diagnosis. So this is just an algorithm. I don't want to keep going so much detail here. When you first get a patient with suspected chronic venous disease, so you need to go with the history and examination, and along with the classification system of VCSS severity assessment. Duplex scan is important. Then exclude the other mimics like the arthritis and other issues. Exclude arterial disease, and if the edema, skin change into ulcer, you need to check. You have to delineate which category it is, and then if there are no contracts like pregnancy, you need to do early intervention. So quality of life is chronic pain is highly problematic in these patients, and reduced mobility is another issue. Psychological burden when you have is very much evident when you have active venous disease going on for so many days, sometimes number of years. That causes so much of a psychological deprivation, social deprivation, because of chronic smelling of the wound. Patients get isolated. Even at home, patient may, if your grandmom or other people having a problem, so you may not be able to ask to come to the kitchen for cooking and all because of the venous ulcer. So this is a highly disturbing to patients, and a lot of socioeconomic costs involved. So controversies include early intervention. It's needed in C2 disease or not. Role of inactive drugs are highly controversial, but only Deflon is proven to be of much value. Optimal duration of compression is we don't know for sure how long. So summary, chronic venous hypertension is biliary venous hypertension. It's a multifactorial pathophysiology, not only one. Compression remains a cornerstone, treatment, intervention guided by anatomy and symptoms of the patients. Take-home messages, chronic venous disease is a hemodynamic inflammatory disease. Duplex is the first approach led by VCSS scoring system to diagnose, and contemporary guidelines favor intervention, and intravenous treatment is the best modality of first-line treatment. Venous ulcers, once there, you have to give compressions along with the intervention for superficial reflux. And these are the references I got. And importantly, treat the hemodynamics, not just the visible varicose. That is the end of my presentation. So if you have questions, you can ask me now. Thank you.
Thank you, sir, for that comprehensive and insightful presentation. We will now proceed to the question and answer session. So we have a couple of questions in the chat box. I think most of them are answered during the lecture. This one question, sir. If a patient has underwent SFL and stripping previously and found to have persistent venous insufficiency after several years, can she undergo ablation?
To a simple answer is yes. We can do ablation. Different modalities are there for recurrent varicose veins. One thing is we can go for even for endothermal ablation like laser, provided there's the vein is not very tortuous. If the vein is very tortuous, laser fiber will not go up. So most of the time, if the vein is very large, usually we can either go for laser or maybe even for recurrent surgery. Sometimes we can do stripping of the affected vein. If there's no demonstrable saphenous reflux, we can just simply step us possible veins. If the vein is very large and tortuous and dilated, and particularly it's very superficial. If the vein is somewhat deeper, straight vein, recurrent vein, we can go for endothermal ablation. If the vein is smaller but recurrent superficial vein, we can go for foam sclerotherapy. So yes, simple answer, yes, we can do any of this treatment based on the duplex scanning. Any other question?
Yes, sir. Similar question, sir. Can laser treatment done for recurrence after surgery?
Yes, we can do for laser, provided that sometimes even if you eliminate the main trunk, there are sometimes accessory vein become prominent. Then that becomes competent again, and then incompetent again later on. So we can do laser even if that is recurrent.
Sir, some asked about the compression stockings and stockings type. How to select the type, and can you elaborate on that?
Yeah,
Couple of people was.
Yeah, in my talk, actually, I elaborated that the type of stockings. This is the stocking. Class 1 is exerting about 15 to 20 millimeter. This is one for mild varicose veins. Start with one simplest thing is tube grip. You can go for tube grip kind of thing. That's for early symptoms. If it is somewhat advanced, it's a class 2 stockings. So there are class 1 and 2 are the stocking types available for varicose vein intervention. Varicose veins symptomatic control. 3 and 4 for lymphedema. So that is simple as that.
Okay, sir. Another question is, if a patient present with primary care with varicose veins C2 without DVT features, is it justified to do duplex scan in first instance to exclude thrombosis before prescribing stockings? Do we need to check ABPI always?
Sorry, do you mind just repeating the question again?
If a patient present to primary care with varicose vein C2 without DVT features, is it justified to do duplex scan in first instance to exclude thrombosis? Before prescribing stockings, do we need to check ABPI or always?
It's like this. When you come across first time patients with varicose veins, first thing is you need to ask the patients, symptoms related to varicose vein or not. That is the most important thing. Ask patients symptoms, their pain, and I elaborate in my lecture. So pain is a very non-specific thing. You need to ask patients if symptoms are related to varicose vein. That's the first thing you need to be worried about. Yes, if the patient's symptoms are related to varicose veins, by asking proper history, then you do a scan. Because if you are, the whole thing about doing a scan is to do an intervention. That's the primary aim, not for just diagnostic purposes. So diagnosis usually by this the history. History tells you a lot of things. If you are not sure, of course, the diagnosis with very vague symptoms, yes, you can do a scan. But having said that, usually scans are indicated for intervention procedures to delineate and then also plan your treatment modality. For you to, if you are having a really about history of DVT in the past, yes, you need to do a scan because it may be a secondary varicose vein. So yes, there's a definitely place for scanning in that sense. And also, ABP assessment is not mandatory in every patient. If you can simply feel foot pulses, the ABPI not usually required. If you are feeling very good bounding foot pulses, usually your ABPI is going to be very normal. So in ABPI is indicated if you can't feel foot pulses. I hope that is clear.
Yes, sir. Some asked about the venous claudication. Can venous claudication occur only when climbing steps? And
No, not really. The claudication itself is defined as the exercise-induced pain in particular muscle group. So exercise can be of any form. It may be just simply walking, or sometimes maybe some of the patient may be climbing. Depending on the magnitude of your walking exercise, your presentation of clinical symptoms might vary. So like in arterial claudication, venous claudication do happen because of obstruction of the deep vein. So because the deep veins carry bulk of the blood, I said 90% of blood drains to the deep venous system. So then the deep veins are blocked. The superficial veins actually have to drive back towards the heart. So that because of that, there's a venous pooling during exercise. So that, of course, is we get bursting type of pain during walking. That is venous claudication. So it's not only during climbing. You can have it in even walking. Okay.
Yes, sir. And I think it's answered the question that can you explain venous claudication more?
Okay.
And so there's another question. Will skin changes reverse once the varicose vein treated?
Yes, that's the beauty of it, but it takes time. You have to warn that this is not going to reverse it all of a sudden when you treat, because these are chronic skin changes which has happened over years, perhaps months to years. So in that situations, your skin changes will not be reversed all of a sudden. It takes a lot of time because your pigmentation due to iron deposition under the skin. So these things are not going to reverse all of a sudden. It takes months. Yes, answer to the question is yes, but takes time.
Yes, sir. Is there? There's another question. Is there? If there is an active venous ulcer to do we still operate in the patient, wait for the ulcer to heal, and proceed with the intervention?
If there's active ulcer, good old practice was to wait until the ulcer heals. But now we know that even if you treat varicose vein and ulcers at the same time, it's going to expedite the ulcer healing rate. That is evident by Euro trial, EVRA trial. I showed you in my talk. So yes, if there's active venous ulcer with active infection, you can't treat because the active infection is a contraindication for surgical, whatever the modality. So, but unless it is actively infected, active ulcer doesn't mean you can't treat. You can treat both. But if you're treating, it's the endothermal ablation, not just a surgery. Surgery has no much of benefit in preventing or expediting the venous ulcer healing. That is evident from ESCA trial done in 2004. But Euro trial is a new evidence that shows that if we treat with endothermal ablation, that's going to prevent recurrence. Recurrence and also ulcer healing rate is faster.
Okay, sir. And another question, sir. How can we differ venous ulcer from a varicose venous ulcer from a diabetic ulcer?
It's simpler because diabetic foot ulcers are characteristically different. The venous ulcer do happen in the gait area, perhaps in and around the ankle area, not in the foot. Usually in the dorsum of the foot, you can get venous ulcers. If you get venous ulcers in dorsum of foot, most of the time it is short venous issues or maybe deep venous issues. If there's a ulcer in the gait area, that is on the medial, just above medial malleus, that is called gait area. That is the venous ulcer. So ulcer by position, you can say this is venous ulcer. Venous ulcers are very superficial and painful and non-healing. And it is there for long periods, most of the time. But diabetic ulcers are usually happening on the plant aspect, maybe as a neuropathy or maybe vasculopathy. When those diabetic patients, they have absent foot pulses also. So that is different. Most of the diabetic foot ulcers are infected. Okay.
Yes, sir. Another question is, can you explain the steps in occlusive strapping? Strapping.
Strapping actually aim to counteract the venous hypertension. So this strapping has to be done incorporating the ulcer bearing area. So that is where the maximal venous hypertension lies. So we have to counteract the high venous pressure at the capillary level by giving the counter pressure from the exterior. That is the basis behind strapping. So we need to exert about 40 millimeter mercury of venous pressure, the contracting pressure. So that is how we maintain that. it is not the number of strapping layers which matter, it's just the pressure that is required. So we need to take effective compression pressure in and around the ankle area. And also in your strapping, you have to incorporate the calf area also, particularly if the patient has ankle mobility issues, like if the ankle mobility is restricted, so you're going to have pooling of blood because of the deep venous insufficiency, because the ankle mobility is restricted. So in that sense, you need to incorporate the calf area also into the strapping technique. All right.
Okay, sir. There are more questions, but I think the time is not permitted.
Yeah. Okay.
Okay,
Yeah.
sir. And with that, we'll move on to the
Yes. Yes. I think.
conclusion of the session, sir.
Sure. I hope everyone understood what I said. Yeah. And thank you so much for the kind listening. And then there was the questions. I hope I have answered the questions enough. Thank you again.
We extended our sincere gratitude to Dr. Veerasuriya for sharing his valuable time, knowledge, and expertise in delivering today's lecture.